Well, welcome everyone to Lucile Packard Children's Hospital. And this evening, our Your Child's Health University lecture topic is eating disorders and late childhood, preteens, early warning signs, symptoms, and treatments. This is the fourth in our series of lectures presented during the month of February for the past few years to recognize National Eating Disorders Month and to bring our eminent physicians and specialists from our eating disorders clinic to you to share their expertise. We welcome you and we're glad you came for this particular topic. I'm Nancy Sanchez from Community Relations, and it's my pleasure to introduce our speakers to you. I want you to know our format, first of all, before I introduce them, in that our speakers will each come up and give a presentation on an area of expertise, their particular expertise. And if you would hold your questions to the end, we will then have a panel, and our speakers will come here and you can ask your questions. Now, our presentation is being videotaped again this evening, as the other presentations in years past are also posted on our website. This will be too on both Stanford iTunes and the Packard Children's Hospital website. So you can catch this again for review in about 3 weeks. I think it should be posted. So it's my great pleasure to introduce our wonderful speakers this evening. The first speaker will be Dr. Kara Fitzpatrick, who's a clinical assistant professor in the Stanford Department of Psychiatry and Behavioral Sciences and Pediatrics. She specializes in neuropsychological assessment of eating disorders and evaluation of treatments in children and adolescents. And her topic this evening is the good, the bad, and the refrigerator. So I'm going to let you wait to hear about that one. After Dr. Fitzpatrick, we have Dr. Cynthia Capon, who's actually our medical director of the Lucile Packard Children's Hospital, a comprehensive eating disorders program. She's a clinical associate professor in the Division of Adolescent Medicine at Stanford University School of Medicine, and Dr. Capon is a board-certified pediatrician and adolescent medicine specialist with over 19 years of clinical experience managing the medical aspects of eating disorders, and tonight she will be talking about the medical complications of eating disorders in young children and tweens. After Dr. Capon's presentation, we have for you Casey Keene Miller. Casey has a degree in nutrition science from Cal Poly San Luis Obispo and did an internship at UC Davis Medical Center where she earned her license as a registered dietitian. And her specialties include pediatrics and adolescent eating disorders and weight management. So her topic tonight will be nutrition and tweens. And then after her presentation, we have Ann Sinha, who is an occupational therapist here at Packard Children's Hospital. She has a master's degree in occupational therapy from Samuel Merritt College, and her specialty areas are working with youth and teens with eating disorders. She's been working with pain patients and also patients that can benefit from biofeedback. And Ann's topic this evening is occupational therapy treating eating disorders in tweens. So we have a really exciting evening of topics for you. And to start out, I'd like to introduce briefly our medical director, Dr. Cynthia Capon. Thanks, Dr. Capon.
Thank you. So I wanted to give you a little overview about what we're going to be speaking about tonight. First is just talking about normal development of eating behaviors and what can go wrong with that. Some medical complications of undernutrition in tweens, and then talk in more detail about nutrition in tweens. We're going to talk about occupational therapy and the treatment of eating disorder in tweens, and then what to do if you're concerned about your tweens' eating behaviors and nutritional status. We thought it might be kind of fun tonight to do it in a Mythbusters format. So fact or fiction, there's a lot of things out there that you hear about eating issues in kids and teens. And so we hope by the end of the evening you'll have a little better sense of which of these might be fact and which of these might be fiction. There's lots of things you hear about. It's fine for athletes to lose their period. It's okay to have a low heart rate. It's always a sign of fitness. It's important not to have much fat in your diet. Only white girls get eating disorders. You can look at somebody and know if they have a serious eating disorder. You only get out malnourished if you're really not eating much. And children get eating disorders because their families are over-controlling, so families should really back off. You never recover from an eating disorder. Anorexia and bulimia are lifestyle choices. Residential treatment is the best option for somebody that has an eating disorder. Kids will just grow out of it anyway. You don't really need to do much. It's normal for tweens to diet. Kids will always eat if they're hungry. And if you medicalize eating issues, they'll get worse. So think amongst yourselves which of these you think might be fact and which you think are fiction. First, a little background. There's a whole spectrum of feeding and eating disorders from infancy through adulthood. We're going to focus today primarily on disorders that can lead to nutritional deficiencies. There's a lot of different ways that eating disorders can express themselves, and it depends somewhat on gender, stage of development, whether an individual has started going through puberty yet, if there's other medical or emotional issues, and even the cultural context can influence how eating disorders present. It's important to note that all ethnic groups and income levels are affected. Sometimes I think within our society there's a stereotype sort of what the typical person with an eating disorder would be. And if anything, I think that we find in our clinic there's a huge array and diversity. And also oftentimes the kids that don't fit the kind of societal stereotype take longer to get to us and come to us in more serious medical condition. So keep a very open mind about the whole range of people that might have eating issues. In particular, we see the prevalence of eating disorders rising in boys and also in younger age groups. We've been rather disturbed to see how young people with classic eating disorders are presenting to us in clinic. There was a study that was done through the late 90s through the mid-2000 up to 2006, and they found that hospitalizations for eating disorders were increasing over 100% in the younger age population, less than 12 years of age. So I'm going to present to you next Dr. Kara Fitzpatrick, Feeding and Eating with Your Preteen, the good, the bad, and the refrigerator.
So I use that because when most people think about feeding their tweens and teens, they think about this huge increase in appetite that's supposed to occur and this widening of choice and preference. I'm actually going to start by going all the way back and talking about the development of eating, because eating behaviors are actually the first independent skill that we give children. Before they can walk or talk, they're actually choosing what they put in their mouth and how they put things in their mouth. And that actually plays a really important role. Kids are actually choosing what they're going to have and when they're going to stop from such a young age that parents often assume that because they can do it at 6 months of age, or actually really at birth, that they're able to do that throughout the rest of their lives. As kids grow older, their taste and texture preferences should be increasing, especially across the first 2 to 3 years. So by age 3, most children are able to and should be eating table food that's very similar to what their parents are eating, albeit in smaller portions or perhaps with some modifications in terms of cutting food up. Interestingly, though, there's actually a little bit of a backslide that starts to occur around elementary school, where kids actually become more limited in their preferences. And you'll notice this narrowing of preferences. The joke that I often have is if you go to any restaurant and look at the kids' menu, they always have the same items on them, right? Grilled cheese sandwiches, chicken nuggets and French fries, pizza, maybe a tortilla with cheese if you're someplace a little bit more exotic. And that's because kids really sort of like those. We're going to actually hold questions until the end. Sorry about that. And you'll often see that kids start to reject vegetables and other things. Now, that's not always the case, but parents often report that these are the kinds of preference changes that they have. And these are also places where development can go awry. We have to remember that feeding disorders can occur as early as infancy and childhood. And once these difficulties are in place, or these behaviors are in place, they become much more difficult for us to move. And they can actually set up a pattern of eating and feeding behaviors that can lead to eating disorders as we get older. So as we make that transition into the teenage years, teenagers should be increasing in their preference, their flexibility in style, the types of food that they're eating. They should again start eating much more like their adult counterparts, and often much more than their adult counterparts. So that's what we would expect with typical eating. So when kids are little, we say open wide for the choo-choo, right? And we can put the food in, and they're able to eat. But what happens when normal development, the way we just described it then, goes off the tracks? Well, an eating disorder is just an abnormal eating pattern that compromises physical health and emotional well-being. And I've put up the types of eating disorders that we'll be sort of talking about. The main ones being anorexia nervosa, bulimia nervosa, and the new one, which isn't actually an eating disorder quite yet, but I think everybody recognizes that it will be, and that's binge eating disorder. And right now that falls under the category of eating disorder not otherwise specified. And eating disorder not otherwise specified is this very broad category of subthreshold eating disorders, and another new category that I'll be talking about called ARFID. What are the problems, though, when we take these criteria and apply them to children? Well, diagnostic criteria, the way they're written, are actually written for adults. There are no child and adolescent psychiatry or eating disorder specialists who are actually informing the development of these criteria, even though eating disorders develop during childhood and adolescence predominantly. And so they may look differently than you think it would look like in an adult. In particular, children and many teens lack that kind of abstract thinking to really have concepts like distorted body image, right? It's almost challenging for us to think about what's distorted. And many kids not only don't have a denial of the seriousness of the disease, they're not aware that they could be ill at all. Another thing is that the frequency and duration of symptoms may be inappropriate for younger ages. They need lower and perhaps more developmentally appropriate targets for significance. In other words, if you need to vomit 2 to 3 times per week for 3 months to meet criteria for bulimia nervosa, I don't know about you, but if I knew my child threw up after eating a meal, even once or twice that wasn't related to illness, boy, my red flags would be raised. And that's actually probably much more significant in children and early adolescence than it is in a much older adult whose body can sustain some of those difficulties. So here are some of the myths that we're going to try and bust. One is that kids will grow out of an eating disorder, that anorexia and bulimia are lifestyle choices, that people never recover from eating disorders, that residential treatment is the best option for teens with eating disorders, and that children get eating disorders because their families are overly controlling, so parents should back off. And that last one in particular is one, even if you go online or listen, you'll hear a lot of people saying that. So hopefully at the end of this presentation, you'll know the difference between whether these are fact or fiction. So what is anorexia nervosa? Anorexia nervosa is a refusal to maintain a normal or healthy body weight. And that can be challenging for parents of some tweens as they're growing and their bodies are changing. There's also a denial of the seriousness of the low weight. In other words, where other people are saying, gosh, I'm worried, these kids are saying, but I look healthy, or even worse, I'm fat, or they don't see the kinds of changes in their body that we see. And there's a significant fear of becoming fat or gaining weight or eating unhealthily. Currently, the criteria also include a loss of menstruation, although that will be changing, thankfully, and a distorted body image. They don't necessarily see themselves as we see them. And you remember that I said for teens and tweens, that's an area where things are a little bit different. Anorexia actually has a fairly young age of onset. The typical age of onset is 14 to 18 years of age. And by that we mean full syndromal presentation by 14 to 18 years of age. So it's important to recognize that catching it early, actually it likely starts in terms of thinking at a much younger age. And we are in fact seeing cases at younger and younger ages, even late elementary school and certainly in middle school. Middle school is a high-risk period because it's a period of increasing independence around eating behaviors. Your elementary school child probably eats dinner or at least certain meals with you, where middle school children don't have the same kind of after-school care. They have much longer periods of time of independence and much greater independence over preparing and eating their own food. But they present with slightly different symptoms that may be difficult for parents to identify. So again, they often don't report feeling fat and instead may have strong rules around being healthy. Your middle school child may go to a health class and come home and say, they said that there's this obesity epidemic and that people are getting really fat, so it's really important to not eat any fat at all. And when Casey Keene-Miller gives her presentation, we'll talk about how that's not true. The other thing you might find is that kids read more labels or become more concerned about what's in their food. Another challenge for parents of tweens and teens is that they may actually not present with weight loss, but rather failure to gain weight. If your child from well child check to well child check over a year doesn't gain any weight, that's actually a significant warning sign, because even if your child hasn't changed in height, they should be gaining in weight because there's increasing bone density, blood flow, brain matter, and organ development that's going on. Some kids are nutritionally impaired enough that they also stop growing. So those growth charts that you get at your well child visit are really important to make sure your child's continuing to track where they should be. Another key signal is a delay of onset of puberty. So kids that simply are not developing, especially girls, but some boys, and when girls aren't progressing toward getting their period, that can actually be a challenge. That's one of the reasons why we're removing the criteria of loss of menstruation, because when anorexia develops in younger girls, it's not that they lose their period, it's that in fact they never start, something we call primary amenorrhea. The thing with anorexia nervosa is that early intervention is absolutely key, and that families are also key in recovery. Most kids develop anorexia nervosa during their teenage years, but they also recover from anorexia during their teenage years. And we actually can get between 50 and 80% recovery rates. And when I say recovery rates, I mean full cure. So we actually get kids all the way better to where they no longer suffer from eating disorders. So one of the myths is that people who've had eating disorders will suffer for them for the rest of their lives. That may be true if they last into adulthood, but for children and adolescents, that's absolutely not true, and a wonderfully hopeful message. The treatment that we know works in the most cases is something we call family-based therapy, FBT, which is sometimes also called Maudsley, which is a little confusing to people. It was named after the hospital where it was developed. And this is not a residential program. This is a program that actually keeps kids in their homes, going to school. It's an outpatient program that generally consists of weekly psychotherapy with the entire family. Bulimia nervosa is often thought of as just throwing up, but in fact what it is a period of a loss of control over eating. So binge eating is characterized by someone losing control over what they're eating. They sit down and intend to eat a certain amount and eat much more. You may notice your child eating much faster, eating larger quantities of food, eating food in a really short amount of time, or having a very high preference for high sugar, high fat, or high carbohydrate foods. And that's why I put that picture that's designed to also make you really hungry. And then those are followed by periods of what we call maladaptive or inappropriate compensatory behaviors, which is really just a fancy way of saying getting rid of the food in a way that's not healthy for the body. So most of us have had the experience of deliberately overeating, right? That's kind of what Thanksgiving is. It's sort of a classical binge episode for families. But afterwards, hopefully, you don't induce vomiting or take laxatives. You just sort of sit on the couch and hope that the food baby passes, and you might join the gym a little bit and work out. What happens in bulimia nervosa is the anxiety about gaining weight is so high that they may induce vomiting, use laxatives. They may also over-exercise, use diet pills or supplements, and they don't always have to throw up, which is what most people think of, or use any of these strategies. Simply fasting for long periods of time after eating so that the profile is a large amount of food followed by acute restriction for a long period of time followed by a large amount of food is enough to qualify for bulimia nervosa. Bulimia has an onset that's much later than anorexia, well, not much later, but it's moved over, where it develops typically around 15 or 16, all the way well into young adulthood. So while older adolescents and young adults are generally starting to be protected from anorexia, they're not protected from bulimia. And it's much less common in early adolescence. But we do see that binge eating tends to precede purging. So you might notice changes in appetite in food being eaten and the way food is being eaten before you see changes that are associated with those compensatory behaviors. It's also important to note that weight's not a good marker. Most kids with bulimia nervosa are of normal weight. and they can look remarkably healthy. They're not losing weight, and they're often not gaining weight either. Rather, paying attention to changes in bathroom habits, using the bathroom immediately after meals, taking longer or more frequent showers, playing music in the bathroom where that didn't used to be a habit, as well as smells and messes, because if anybody's ever had a kid with a stomach flu, it's really hard to get that acrid smell of vomit out of your house. Those can also be signs. As can secretive behavior, but I tend not to put that in too much because really that's kind of a healthy thing in a lot of adolescent development. We also know that bulimia nervosa can be cured as well. We know a little bit less about the treatment of bulimia in teens and tweens. In fact, there have only been 3 real studies. We're finishing the 4th and the largest study ever done. And what we know is that actually more treatments work for bulimia nervosa than anorexia nervosa. In particular, family-based approaches, as what I talked about, that Maudsley approach with anorexia, is also effective with bulimia nervosa. And there are several individual therapy models, including cognitive behavioral therapy and interpersonal psychotherapy, that are useful. Cognitive behavioral therapy really focuses on thoughts, feelings, and behaviors, where interpersonal psychotherapy focuses on relationships and sort of establishing improved coping socially and with the people in their lives. Currently, binge eating disorder falls under eating disorder not otherwise specified, but will be its own disorder when the DSM-5 comes out sometime, hopefully, in 2013 or 14. And this is particularly important for teens and tweens because it's characterized, again, by those feelings of eating that are out of control, but it starts much younger than bulimia nervosa. We see binge eating as young as 7, 8, and 9 years old. And sometimes parents say, well, my kid's a real emotional eater. If they've had a bad day, they'll come home and eat a lot of food. Or they really have a high preference for high carbohydrate, sweet, rich foods. For girls in particular, binging can also occur in social relationships. Any of you who've had the pleasure of hosting an all-girl slumber party might know that it's sort of like a binge fest. You know, you bake brownies, you put other things in it, you make chocolate speedballs, you stay up all night. And so there's often this socially sanctioned overeating followed by periods of restriction. One of the other new disorders is something called ARFID, which I happen to think is a terrible name because it sounds like other horrible things. But what it stands for is Avoidant Restrictive Food Intake Disorder. And you might also think about this as extreme picky eating. And when I say extreme picky eating, I don't mean my kid really has a strong preference for the things on that childhood menu, but rather it's children who have difficulty taking in food by mouth and have an extremely limited diet. I work with a 12-year-old currently who only eats jarred baby food, which you can tell would be very developmentally atypical, and yet he's a developmentally normal child who's otherwise in school and doing the things that he should be doing. We can typically tell this pattern as early as age 5 because where kids are going from that sort of 3- and 4-year-old eating, their preferences become more and more narrow rather than broadening. And they often fail to introduce foods in early childhood and infancy, and there's a strong preference for what we call the beige diet, breads, carbohydrates. These children are often so specific that they can taste the difference between brands of peanut butter. If you gave me a Skippy Jif kind of thing, I probably wouldn't be able to tell the difference. The kids that I work with can smell the difference before they even taste it. Many also have a high gag reflex. So when we talk about those normal feeding and eating things that we would expect to see, yes, it's common that your teen or tween should be eating more. They have a higher metabolic need. Often they're working out more or more physically active. They're in school for longer days. And some may experiment with skipping meals. This is currently quite popular in middle school. Any of you who have middle schoolers, the girls in particular will skip meals, or they'll say, we don't have time to eat. And so there's also a real culture around what kids are eating. It isn't healthy, even if it's typical. So it's also not healthy or typical for kids to diet during this age. Even kids who are slightly overweight, we actually encourage increasing exercise and growing into their weight rather than losing weight unless their BMI is very, very high. At other times, you may be worried that your child is binging, but they're really just having access to strongly preferred fun foods that they wouldn't get elsewhere. So the things we want to do are really to be watching for changes in eating, weight loss, weight gain, or changes in eating behaviors or bathroom habits that may signal problems. It's important to remember an eating disorder is an abnormal pattern of eating, and it will compromise both physical as well as psychological health. Many patterns that you see lead to nutritional deficiencies, and those nutritional deficiencies alone can actually cause more behaviors that look like eating disorders. Said differently, kids who restrict their intake and diet actually become more rigid about what they're eating, more fearful of eating, and therefore eat less. So it becomes a little bit of a self-reinforcing cycle. And kids, especially tweens and early teens, can become medically ill very quickly because of the changing demands on their bodies and the need for their heart rates and other things to be higher. They can become ill very quickly. So it's important to go with your gut. If you think that your child is not eating an adequate amount, a range of food on a regular basis, if you feel like they're exercising excessively or vomiting, please, you've got a problem. We find that most families don't come to us until eating disorders have been in place for a year or more. And that's with parents being vigilant. If you think you have a problem, please don't wait. Like I said, most families wait until their child's been ill for a year or more, and we know that treatment's actually more effective and you need less of it the earlier you come into treatment. Finding a specialist is also critically important. Many families are reluctant to bring their child to a specialist because they may be concerned about pathologizing their child or creating an illness where there isn't one. But eating disorders are actually incredibly complicated and difficult to treat illnesses that require a team approach. You need to find someone who knows both adolescents and children as well as eating disorders, and someone that you can trust. So on that note, to let you know what happens, I'm going to turn this over to Dr. Capon, who's going to talk about medical complications and how tweens are different from adolescents and adults.
Thanks. All right, so I'm going to talk about medical complications in general, but we're going to pay particular attention to the areas in which tweens are different than the general population. There's a few potential facts or fictions that I was going to throw up first. One is you can tell by looking at someone if they have a serious eating disorders that they're just psychiatric problems, not medical. It's okay to be skipping your menstrual periods, low heart rate, low blood pressure, signs of fitness, and we talked about the medicalization one. Tweens are different than adolescents in the sense, and even adults, because there's particular periods of development that are especially important. And the reason why we get especially concerned about malnutrition in children and tweens is because at those critical areas, their long-term growth can be impacted. When you look at older teens who are diagnosed with anorexia compared to children who are less, the younger children present at lower weights compared to what would be a normal weight for age, and they are also individuals that lost weight more rapidly than the older individuals. When you look at children from age 5 to 12, there was a Canadian study that was a population-based survey. There were more girls than boys, and we see this in the older adolescents as well, about 6 to 1. But still note, there's still a significant number of boys in this population. Half of these individuals already had delayed growth. Nearly half also were at very low weight for height. A third of them had abnormal vital signs, and we'll be talking more about that in more detail in a few minutes. Low blood pressure, low heart rate, or low temperature, except only about 2/3 of these individuals would meet actual criteria for an eating disorder. So even though we see very serious complications in this population, they wouldn't meet the classical criteria that you would describe. No matter how you get malnourished, whether it's because of a medical illness, whether it's because of a psychological problem, you still end up affecting all organs of the body. So physical effects are similar regardless of how you get there. You can have both the short and long-term medical complications, and potentially these complications can be life-threatening. The changes that we see in heart rate, blood pressure, and temperature are due to malnutrition or weight loss. We can see it even in people that have not had weight loss if they've been purging or doing extreme activities to try to lose weight. There's a kind of hibernation response, and in a way it's the body's way of trying to protect itself when it's not getting enough nutrition. It's important to see that you can even see these in individuals that would otherwise be considered overweight. When you think of a bear going into hibernation, it's going for the winter. It wants to slow everything down, the low heart rate, the low blood pressure, the low temperature. It's a way of conserving energy and letting that bear get through the long winter there. And same thing with eating disorders. It's a way of compensating for malnutrition and lowering everybody's energy needs down. And your body's effectively shifting into survival mode. So the blood's going to go mostly to your head and your heart. Those are important organs. You got to keep them going. Everything else is kind of extra. Hands, feet, it's not as necessary. So oftentimes you'll note that people have cold hands and feet and poor blood flow there. And in particular, and this is what's especially concerning for youth, is growth and development is put on hold. You don't want to be spending a lot of energy growing if you barely have enough to be surviving. The complications that we get most concerned about short-term are the ones affecting the heart, because it could be potentially even some lethal complications with that. We see the low heart rate, which we call bradycardia, low blood pressure. We also see when you go from a lying position to a standing position that the blood pressure might drop or the heart might speed up in the rate. And sometimes people will notice dizziness as well. Heart failure can also be seen in individuals that are malnourished, or there can be some chemical abnormalities that we note when individuals are vomiting, and that can affect the heart also. Children's heart rates in general are higher than teens, and when you have somebody that's involved in intensive athletic activity, that may actually lower your heart rate. But even in elite college athletes, maybe down into the 40s or the 50s, potentially you would see that. But it's unusual to have somebody that has a heart rate in the 40s. And generally, heart rates in the 40s are not normal for teens. And in addition, whatever you see during the day, oftentimes your heart rate's even lower at night. For all of us, our heart rate would be lower when we're sleeping. So we get particularly concerned when we see somebody with a heart rate in the 40s at night, then oftentimes those individuals may even have a pulse in the 30s when they're sleeping. Nutrition, to me, is like the rocket fuel. So when you're going through adolescence, you want your rocket to take off. You want to be doing growth and development. And if you don't have adequate fuel, your rocket's not going to take off. You're not going to be growing and developing. A lot of action happens during adolescence. About 25% of our final adult height occurs during puberty. The heart doubles in mass during puberty. Bone mass increases by nearly 50%. And it's also important for us to have appropriate changes in our body fat during adolescence. We start off with about 16% before puberty, and in adults it's 27%. And that's important because the body fat's necessary for making appropriate hormones to direct the body's growth and development. The brain has achieved most of its final adult mass at the beginning of adolescence, though it continues to change a lot in function, and that's important to have good nutrition for that as well. I wanted to put this up just so you can sort of see over the trajectory. The bottom is age of years, and then the percentage on the left side is the percent of final adult body weight that's achieved. And so if you look at adolescence, by age 10, most of your brain development has occurred. About half of your physical growth has been achieved by that, but the other half needs to occur during adolescence. And practically all of your sexual development occurs during the adolescent period. The hormones are very much affected by nutritional deficiencies during adolescence. When you have normal sexual development, the brain signals the body. Ovaries then develop and produce female hormone estradiol, and testicles in boys will produce the male hormone testosterone. Eating disorders, however, suppress hormones that are needed for growth and development. We can see that puberty doesn't start at all or may be delayed, and there's potentially irreversible changes that happen with that, including increased risk of weak bones or bone fractures, and slow growth or even ultimately short height as an adult. For males, there can be a delay or arrest in the development of testes and penis growth. You can also have atrophy or shrinkage of the testes if the sexual development has already begun. Sperm production can be delayed. If boys have already been developing erections or wet dreams, they can lose those as a sign of the decrease in the male hormone. And muscle development also can be affected by that. For girls, you can have a delay or arrest in development of breasts or actual shrinkage of breast tissue if there's already been development that's taken place. There can be a delayed start of menstrual periods or loss of menstrual periods. During the first 1 to 2 years after you start your menstrual period, it's actually quite common to have irregular and skipped menstrual cycles. That's fine. But once you've established regular menses, it's not normal to be skipping periods on a regular basis. So it could potentially be a sign of a medical problem, a thyroid disorder, or even pregnancy. But if you've looked at other medical possibilities for that, if you have somebody that's losing their periods, it might well be that they're just not getting adequate nutrition for their level of activity. There's something we recognize now, the female athletic triad, and there's 3 components. One is from inadequate intake to actual disordered eating, irregular menses or amenorrhea, complete loss of menstrual cycles, and impaired bone development to the extreme of osteoporosis. It's basically caused by an imbalance between energy intake and output. If you see somebody with secondary amenorrhea in athletes, this is one of the common signs of this. And it's common, particularly in sports that are emphasizing a lean weight or body mass. So things like gymnastics or running or dance, these individuals might be particularly at risk. We've also had some crew people, anybody or wrestlers, people that need to be a certain weight to be doing their sport well. Bones are at particular risk during adolescence. Nearly half of your bone mass is achieved during this time, and by the end of your growth spurt, about 17 years of age, about 90% of your bone as an adult has already been laid down. We see half of the teens with eating disorders develop problems with their bone strength. We see it in boys and in girls, and we also see it in individuals that are normal weight, not just individuals that are low weight if they've got disordered eating. There's partly, one of the reasons is because of lack in calcium in the diet, but that's not it. You can't make up for it just by having more calcium. It's also because of the hormones that you need to direct the calcium to the proper places to build up your bone strength are lacking with that. And ultimately, your peak bone mass is achieved by the end of adolescence, and then over time, during adolescence, you can put money in the bank, you can take money out of the bank. But once you become an adult, you're basically going to be losing bone mass over time. You can't be gaining bone mass by and large. So it's really important to have a good bank account at the end of your adolescent time. These are some pictures of individuals with bone issues. The person on the left is a normal, healthy skeleton, so the white is good, it's strong calcium in the bones, and you can see the vertebrae there is strong, it's got good structure, it's going to be a strong vertebrae. On the right side, that kind of ghost-like picture is somebody with more severe bone loss, and they've lost that structural component of the bone. And then the vertebrae on the extreme far side, lots of areas where potentially there might be bone collapse. There's also a number of gastrointestinal complications with individuals that are restricting intake. Things slow down. Movement of the food goes slower through the gut. And that can lead to abdominal pain and discomfort. It can lead to bloating, constipation. Sometimes there can be a cycle where somebody's feeling uncomfortable because they've become malnourished and they've got some stomach complications related to that, and then they restrict more because of the abdominal pain, and then that just makes it worse with that. There also potentially can be some effects on the liver from starvation and the refeeding process. We get particularly concerned about the gastrointestinal complications in individuals that are vomiting. The stomach's really well designed to withstand acid, but the rest of us is not. So when you're purging, you have acid coming up through the esophagus and into the mouth, and all of these areas can be severely damaged by exposure to the acid. In the esophagus, you can get bleeding or ulcerations, even acute bleeding and blood loss from that. And in the mouth, commonly what we'll see is a loss of the tooth enamel with that. So that picture that I have there is you just see more of the tooth than you should. You can actually even get down to the roots. You might have more problems with cavities and tooth decay. And parotid gland enlargement is another sign that we see oftentimes in people that are purging. And it's fullness at the back sort of jaw area. So if you see somebody with fullness there, that might be somebody that has been engaged in repetitive vomiting. We get also concerned about the chemical effects of vomiting. When you throw up, you're not just throwing up food. You're throwing up some chemicals that are really essential for the body. One of the main ones is potassium, and potassium is critical for the heart. If you have low levels of potassium, the heart can stop beating and you can have sudden death. Phosphorus is also very important and can get lost both in individuals that are vomiting and also in individuals that are severely underweight. If you remember back to your college chemistry classes, we have ATP, and the P is phosphorus. And that's basically the fuel of the body. Everything that needs energy in the body, you need to have ATP for that. So in the heart, it can be affected. You can have heart failure, sudden death. The diaphragm, the breathing muscle, gets affected by low phosphorus. You can have problems with breathing. The brain, you can have confusion, seizures, coma, and also just general muscle weakness as well. One of the things that I find most personally disturbing is its effect on the brain when you're malnourished. On the left side, you have a normal brain, and the white's good. The white is basic thinking tissue of the brain. There's a rich brain volume there. There's great connections between the neurons there. And on the right side of the slide, on the malnourished brain, the darker areas are areas where fluid has filled in. There's actual shrinkage of the brain tissue, and the fluid-filled areas fill up more of the brain. And we see less richness of the connections between the brain tissue. There's work being done actually by Dr. Golden in the audience, looking at the brains of individuals that are malnourished. But the studies that are done to date suggest that while there's an improvement when somebody becomes renourished, that we're not really sure if those changes can be fully reversible. So that's one of the particularly scary aspects of the disorder. We see in patients that have become lower weight what we call organic brain syndrome, where they're kind of, I put the hamster in the wheel kind of thing. You just get the feeling like you're talking and they're stuck with their thinking. They can't really move on past that. A lot of rumination, obsession, distortions in thinking, difficulties with basic decision making, and potentially some short-term memory loss. And this is why it's so critical to get to somebody to a better weight. And I think it's one of the reasons why the family-based treatment is so helpful. Because before we used to focus on trying to get people to understand what was going on first and then try to get better with their weight. Now we kind of go the other way around. We try to help people get nutritionally in a better place because the brain just doesn't work effectively when it's at very low weights. You also get distortions in your self-assessment and weight that can be worse as you lose more weight. And we kind of see it as an eclipsing of the self by the eating disorder. You feel like you're talking to the person, but the person's not really there anymore. It seems like more and more of what you're hearing is the eating disorder speaking instead of the individual. So we try in therapy to separate the two and find the person that's hiding behind the eating disorder. I put this up just, these are not necessarily things you would see, but if you do, you might be concerning for you. Lanigo is kind of fine baby hair. We see that sometimes in people that have gotten particularly malnourished. Many times, by the time we see somebody, they are not using their hands to purge, but if they do, sometimes there can be some scarring of the fingers from induced vomiting. And you can also get some hair loss as well related to that, or sort of dry hair from the fat restrictions. Your first line of action would be to talk with your primary health care provider if you're concerned about medical complications related to eating disorders. It's really important for a provider to identify the eating disorders early, and a lot of times they'll be able to notice patterns in the trajectory because of the long-term relationship they've had with you and your child. And as discussed, it's really critical to attack these issues early on to prevent the long-term complications. When you go for your initial medical assessment, they're going to be looking for physical signs or symptoms that suggest a potential underlying physical illness. Sometimes we've had individuals sent to us that have primary physical illnesses. Other times we've had kids that have been identified with a disorder like celiac disease or thyroid disorder that also have eating issues on top of that. So your doctor should do assessment to make sure that there's not anything medical and organic that's being missed and causing the weight loss. They're going to look at whether a child's fallen off their normal growth and developmental trajectory, and then look for whether there's already serious medical complications like low heart rate or blood pressure, and decide whether it's safe to continue evaluation as an outpatient or whether somebody's already needing more intensive medical treatment in a hospital. They should be encouraging you as a family to be supervising and taking charge of your tweens' food intake and advocate for you to help get appropriate services and help you establish an appropriate treatment team. And we'll be talking more a little bit about this at the end as well. And then over time, monitor progress for your child and coordinate care. It's important as a medical provider to help contain the eating disorder, to establish clear limits of safety for when somebody is doing okay as an outpatient and when they might need a higher level of care. And also for people that are really severely malnourished. It's important to be in a hospital setting for safety reasons. We see more complications in that age group, and they're also just more challenging to treat. The medical complications that we would potentially hospitalize somebody on a medical ward are the following. For low pulse, less than 50, we would hospitalize a child or adolescent. Low blood pressure, less than 90/45. A low body temperature, 36.3 Celsius, or when somebody goes from lying to standing and we recheck the pulse and the blood pressure, if the pulse shoots up by more than 35 or the blood pressure drops more than 10, we would consider any of those things reasons to hospitalize an individual on a medical unit with more comprehensive treatment. Severe malnutrition, less than 75% or 3/4 of a normal body weight. Severe dehydration, if there's electrolyte problems with potassium and phosphorus, as we discussed. If there's problems with the heart rhythm, or if they've had some sort of acute medical complications, so fainting or heart failure, seizures, if they've got intestinal bleeding. It's a very slippery slope, and one of the scary things that we see is oftentimes once you start losing some weight, it just snowballs. So you can get somebody that starts with a little bit and then it gets out of hand very quickly. So it's important to remain open to the possibility of having an eating disorder. It's great to be, and it's very easy to get into denial about this. You don't want to really acknowledge that what you're seeing might truly be an eating disorder. But that's the eating disorder's best friend. You need to keep an open mind about that possibility in your child. And if you are concerned about an eating disorder, you should get very close follow-up. You should come for an initial evaluation, but your physician should be seeing you frequently, every week or so, until the problem's resolved and you're on the right track. The risk of medical instability increases when you have somebody that's losing a larger amount in a shorter amount of time. And when in doubt, seek help, get appropriate evaluation for your child. It's much better to present before you really needed to than to miss diagnosis that's been going on for a longer period of time. Next, I'm going to pass you to Casey Keene-Miller, who's going to talk with us about nutrition for tweens.
Okay. So I'm going to do my own Mythbusters here, and as you're listening to this whole presentation, it's important to think about these next few statements and whether or not you think they're fact or fiction. So the first one is that healthy diets contain minimal fats. You only get malnourished if you're really not eating much at all. It's normal for tweens to diet, and kids will always eat if they're hungry. Hopefully by the end of this segment you'll be able to answer those. As Dr. Capon has already talked about, adequate calories are especially important during the tween years as they're storing up for their biggest growth spurt. And deficiency may cause immediate and long-term effects on multiple organ systems and on normal growth and development. It's also important to know that athletes require additional calories. So for those of you that have children that are athletes, they're going to require way more calories than their non-athlete peers. And for all of us, an energy imbalance can lead to weight loss or weight gain. And in a child that's about ready to start their biggest growth spurt, energy in has to equal energy out. And if there's an imbalance, there will be problems later on down the road. For most parents, I don't actually recommend for you to talk with your child about specific calories. A lot of our tweens they're highly impressionable. They take one statement and they run with it. And so if we're talking about calories with our tweens, they might take that number and think that that's what they need for the rest of their life. And as we've been talking about today, our nutritional needs change, but they're especially high in the preteen and adolescent years. So I just wanted to put this slide up here for your own reference. Please don't talk about it with your child. Hopefully clinicians or primary care physicians aren't talking about calories with your children because we know that they change, and our children need to know that, but they don't need to hang on to every last detail about their calorie needs. In order to figure out what calorie needs our children have, we use the dietary reference intake, which is a big, long calculation that I won't get into tonight, but it basically shows that for girls and boys, for different activity levels, they have different calorie needs. And for girls from ages 9 to 13, typically a sedentary girl might need about 1,600 calories. A moderately active tween, which is somebody who's doing about 30 to 60 minutes of activity a day, is going to need 1,600 calories to 2,000. And an active tween girl doing about 1 to 2 hours a day will need anywhere from 1,800 to 2,200 calories. And for boys, the numbers are a little bit higher, anywhere from 1,800 calories a day to about 2,600 calories a day. But again, it's really important to note that our active teenagers or tweens, they're going to need oftentimes 1.5 to 2 times the amount of our non-athletic teens. So it's important to keep that in mind. Tweens also have increased vitamin D and calcium levels, as Dr. Capon was referring to. Their bones are storing up. Their calcium needs are about 1,300 milligrams per day, and they need about 600 international units, or IUs, of vitamin D. Most of our tweens can get these from an adequate intake of dairy products such as milk, yogurt, and cheese, and being out in the sunshine, although I know that we're supposed to be teaching them to put on sunscreen, so that's not as helpful. If your child is not taking in adequate amounts of dairy, which would be about 3 to 4 servings a day, then they may need a supplement, and that's important to talk about with your primary care physician and dietitian. Pop quiz. I want you to think for yourselves a minute. What organ in the body has the highest % fat? And if you're thinking the stomach, that's not true. It's actually the brain, as we talked about earlier. The brain is about 60% fat, and we know that with inadequate fats, now after listening to Dr. Capon, that the brain does shrink in size, and so it's really important to emphasize the fats that your child needs to have. Not only are dietary fats important for brain health, but they also provide structure for all cell membranes. And they're an important fuel for muscles, not just carbohydrates, but also fats. They deliver fat-soluble vitamins A, D, E, and K, and without fats in the diet, we can't properly utilize those vitamins. They also form the base structure of many hormones in the body, which again is very important during the adolescent years. Normal hormonal function requires dietary fat to be present in these quantities. About 30% of calories from fat, total calories, need to come from fat. 10% need to come from saturated fat, which are those solid fats such as butter or fats that we find in animal products. It's also important to get adequate amounts of essential fatty acids. You've probably heard of these. There are omega-3s and omega-6 fatty acids, and the name says it all. They are absolutely essential, which means we cannot make them in the body. Our body can't survive without them, and we have to get them from our diet. Essential fatty acid deficiency can lead to slowing of brain function, shrinkage of brain tissue, dry skin, hair loss, skin rashes, and even growth retardation. So you may have seen this before. If you haven't, this is the new version of the food guide pyramid. I'm sure all of you are familiar with that. I think it was in 2010 they released this plate diagram, which I actually find quite useful for the general population. It shows us that we need to fill our plate with fruits and grains, vegetables, proteins, and dairy. But I always like to make note of the fact that it doesn't show fats. And we know, as we've just talked about at length, that we need fat in the diet. So when talking to your tween or having discussions about this model, if they're coming home with this from school, it's really important to emphasize that we need fats in addition to all these other food groups. It's also important for tweens to eat 3 meals and 2 to 3 snacks every day. They're going to be turning over cells every second of every day, and they're growing at incredible speeds. And so they need to have regular intakes of calories throughout the day to keep their energy levels up. As parents and teachers and whatever else you do with the tweens here, you're advocates for these children. So it's really important that you encourage family meals. Sitting down for a family meal as many days of the week as possible, no matter how busy you are, is one of the best things you can do for your tween. It's important to encourage mindful eating, which means no electronic devices at all during dinner hour or breakfast hour, so that the child can actually focus on the social aspects of eating. They can focus on the enjoyment of eating, the pleasure of food without distraction. It's important to avoid food talk. We all talk about food. It's in every message that we hear every single day. And it's a really critical time mealtime is really critical for children to be able to not think about the dietary components of food and just learn to enjoy it. Cooking together and trying out new recipes is also important, and getting your tween engaged in grocery shopping and learning about new foods, trying new variety, and also involving them in food preparation can be very helpful. And this is for the general tween. We'll get to the eating disordered tween in a moment. You also need to be an advocate for healthy foods in schools and at organized activities such as your child's sports teams or clubs, Girl Scouts, you name it. It's important to make sure and advocate for healthy foods. And to be a positive role model. Your child is listening to you and watching you every moment of every day. And so if you're modeling good food behavior, they're going to learn from you. And remember, tweens are impressionable. So we want to encourage health at every size. There's not one size fits all. There's a bunch of different sizes, and every tween can be healthy at that size as long as they're getting proper nutrition. Now, dieting and eating disorders we know go hand in hand. it's really important for us to encourage sustainable dietary changes, little small steps that will help us be healthy over time rather than diets. We all know about crash diets. They never work. So it's important to teach our tweens that healthy, small changes make a big difference. We know that when compared to non-dieters, 14 to 15-year-old girls who engaged in strict dieting had an 18 times risk of developing an eating disorder within a 6-month period, and a nearly 20% chance of developing an eating disorder within 1 year, which is pretty scary. And girls who dieted moderately had a 5 times risk of developing an eating disorder within 6 months. So dieting, no matter what it's for, could lead to an eating disorder, which is a scary thought. Now, what to do when normal becomes abnormal? You may find that your tween has stopped eating an entire food group. They're eating much less than they used to. They stopped eating with the family. They might try to get out of eating with your family for a variety of reasons. They're consistently skipping meals. They're reading food labels and counting calories or fat grams, carbohydrates or sugars. And they're increasingly wary of food preparation methods. This is abnormal. Another important thing to recognize about your child is the overweight teen, or tween, excuse me. A lot of children, if they're overweight, dieting or losing weight might go unrecognized, or it may be thought of as a good thing. But many adolescents who develop eating disorders were previously overweight. And in overweight adolescents, you really want to watch for elusive weight loss goals, loss of menstruation or periods, unhealthy weight loss practices such as vomiting, diet pills, laxative abuse, all those red flags that Dr. Fitzpatrick talked about earlier, rapid weight loss, or large fluctuations in weight. These are all signs that something's wrong. We talked about the increased nutritional needs of the tween, the average tween, but we also know that the needs are extremely high in a tween with an eating disorder. Their metabolic needs increase, so it's important to, again, encourage 3 meals and 2 to 3 snacks a day so that they're getting continuous influx of energy all day long. It's important to use calorically dense foods. Many tweens that have an eating disorder will complain of belly pain, bloating, gas. They're physically uncomfortable, and this is real. It's not something that they're making up. They're physiologically uncomfortable because, as Dr. Capon referred to earlier, their gastrointestinal system is slowed down. And so the food that's in their body is going to be moving more slowly, and it's going to be difficult for them to eat the right quantity of food to meet their needs. So you want to use really calorically dense foods, adding fats again to foods, using foods that are low in fiber. Liquid calories can be especially helpful, using things like whole milk or 2% milk instead of non-fat milk, smoothies, juices, milkshakes, things like Ensure or Boost, which are just nutritional supplements. These can be really helpful to help your child with an eating disorder be able to get in the quantity of calories they need without feeling completely uncomfortable. And again, to talk a little bit more about the specific intervention that we use, this Maudsley method or the family-based treatment approach for treating tweens with eating disorders, you may be wondering, what's the dietitian's role? How does that fit in? And as a dietitian, I'm typically talking about food and nutrition and the nutrition goals with all of you rather than with your tween. I try to avoid a lot of food messages with the tween who has an eating disorder because it's something that they're going to perseverate on. It's something that they really need to get away from for a little bit. They need to be able to take a break from thinking about food messages and nutritional needs and allow their parents to take over that role and be able to decide for their child what they really need to be getting in every day. You all have fed your children their whole lives, and up until they developed an eating disorder, they were doing okay and growing fine most likely. And so as a dietitian, we always trust the parent to make the judgment about food and nutrition and what their child needs. And so I'm not going to be giving you a ton of nutritional advice, but I will be giving you general tips, such as, like I talked about previously, choosing calorically dense foods, having your child eat regularly 3 times a day with snacks in between, making sure that they're not having high fiber foods, making sure they're getting in all the nutrition so that you're actually seeing them eat the food and finish the meal. That's going to be the dietitian's primary role initially in this type of a model. We want to empower our parents to help refeed the child. Again, you're the best role model. You're the ones that know your child best, so it's important for you to be on the front line to make sure that your child is eating. So now I'm going to hand over to Ann Sinha, who's going to be talking about her role as an occupational therapist.
It's been requested that I speak quickly, so I will, and I may not go over every word of every slide. So just a brief on occupational therapy. Basically, we're looking at someone's functional level, seeing if there's currently any barriers to reaching their highest potential, and then addressing those. Why do we particularly work with patients with eating disorders? It's our background in feeding, that ability to really look at their current function and helping them get back to their normal roles and lifestyle issues. You know, even like socialization, when a person develops an eating disorder, they might not go to a birthday party because they're afraid of the cake, they can't eat the pizza. There's so many small ways that get really impacted. This is a bit of a list of who might benefit from occupational therapy for feeding. I won't read every word, but we're going to go into a few of them shortly. So you might consider involving an occupational therapist, not in every case, but if there's a swallowing or oral motor difficulty, any sort of food phobia, post-choking or illness, if there's vomiting associated with stress or emotional issues. So I'm not talking about bulimia, but other issues. Severe food aversions or oral aversions, we mentioned ARFID, somatic symptoms or abdominal pain or psychological patterns affecting physical abilities. So some of these we've covered a little bit, but also to mention fact or fiction, never feed a child who complains of stomach pain. There's nothing that can make a picky eater eat foods that they don't like. And training the mind can't help with physical pain. I was asked to give a couple examples of some areas where we may treat patients. One is when a patient has a food phobia. A phobia in this case is initiated by an event such as vomiting or choking, and all of a sudden someone that was eating normally becomes more and more restrictive in the amount of intake that they take. The food phobia is different than a traditional eating disorder in that often they're more hesitant about certain textures or types of foods. They'd be more inclined to eat yogurt, but not a granola bar with yogurt on it because it's too crunchy. They have normal ideas about their body shape, whereas with an eating disorder, it would be distorted, and they'd be avoiding fats and high-calorie foods. When I work with a patient that has a food phobia, I'd actually be doing meals with the child to help them overcome those barriers. Sometimes the parents at that point have done so much, and they're so frustrated. Often we're developing a behavior modification program looking at what is their specific motivators and how can we help them overcome those issues. Definitely relaxation, coping, insight skills. Also, we might work with the extremely picky eater that we mentioned with oral aversion, ARFID. Those patients, you have to start with really small steps. You know, I always tell those parents, it's probably going to be a year of us just working together, and sometimes it's going to feel slow. But, you know, if you take a patient that's eating so few things and you introduce a food group like a milk, you know, I mean, that's sometimes a major barrier, or you know, a vegetable. It can be a huge accomplishment. And, you know, in the hospital, it happens much faster when we get sent those patients, but we also see them outpatient. I also just see patients in general to work on, again, looking at a patient's function. So many patients say, when I'm stressed, I have more difficulty eating, you know. And that's true for many people across the board. But when you take someone whose eating is already abnormal and they're stressed and they're not eating, it becomes a huge issue. So I'm often working with these individuals on just coping strategies to use in these situations and developing insight. They might not even know, you know, so that becomes a critical factor. This is a little chart that just goes over some of the populations that we treat and some of the treatments that we would do. So coping strategies is pretty much across the board. I wouldn't necessarily be doing meals most of the time with someone with anorexia or bulimia, whereas where it's a phobia patient, I almost always will need to work with those patients, or ARFID patient. So just a few notes for what I would hope for from parents as an occupational therapist. I think we've already said don't wait to come in, assemble your team, be consistent with the physiological monitoring from your doctor. And also I put be available throughout the session. Sometimes parents are like, you know, I may not do every minute with the parent, but I always have them in at the start, at the end, sometimes throughout. So if they kind of leave and aren't, you know, anywhere to be found, that can be an issue. I know that some people have traveled from other places and that this is going to be shown remotely. When you're looking for finding a feeding professional, you want to look for someone that has experience treating children and teens with similar issues. Here, send them to us, to the occupational therapist, right, if you're in Palo Alto or nearby. But in other states, sometimes that person might be the psychologist or the speech therapist. It can vary, to be very honest. You do want to ask if the therapist is going to sit and eat at nearly every session with your child. Again, not necessarily with anorexia and bulimia, but with some of these other areas mentioned. Are they going to develop a home program after a few sessions with the parent and involve the parent? That's across the board. Do they have experience developing behavior modification programs? Very important. And what percentage of their caseload involves these patients and how many years experience? This you really want, you know, if you're going to invest the time. This is just a little note for how do you get an OT order. Parents always ask me this. You want to have the doctor write OT, eval, and treat, the diagnostic code, often feeding difficulties, sometimes anorexia, et cetera, and the physician's number. Usually feeding difficulties is what's reimbursable, okay? I'm going to skip this for time. So just some other general recommendations for parents that haven't been mentioned. Really monitor your own language as it relates to your body and food. Speak positively. You think that kids don't listen, but they really, really listen. And if you speak negatively about your own body, it impacts them, and they're more likely to do it. Avoid overgeneralizing about what they can't do and they cannot do. You know, a lot of the families come to me, oh, they'll never eat that, they'll never do that. You're just setting yourself up for failure. So you really want to avoid overgeneralizing. Do tell me everything one-on-one, but not in front of them. Also be careful about how you talk about exercise. You know, I've had some patients that, you know, the parents are like, oh, let's go get fit, you know, and they're anorexia, and she's like, oh, it pings me every time it's said. So you want to really watch how you talk about movement. Make movement, you know, we all know it's great, you know, just for the fun of it, for the sake of it. And also avoid any strong statements about one food group, because this can create an artificial attraction or aversion. You know, so many times, especially with these tweens, they develop an eating disorder right after health class. You know, the health teacher will say to them, you know, sugar's not good for you, so they decide to cut out sugar. Just blanket cut it out. And that alone just sends them in the cycle, and then, oh, sugar's bad, maybe I should cut out fats. And it, you know, when the mind starts restricting, it just tends to restrict more and more. It's the nature of the mind. So you really want to watch your own statements. Or, you know, what can happen is sugar's not allowed, how am I going to eat it? I'm going to sneak in the back room and eat it. You know, you really want to be careful about that. So I'll pass the baton here.
We are going to whiz through this very last section because we want to leave time for some questions at the end. But we just wanted to mention about an effective team to help you treat and evaluate the kids. One is to go with your instincts. If you're concerned about your child, get appropriate care for them and assessment, and make sure that you're a strong advocate, and don't be satisfied until you feel like you've gotten what you need for them. It's very important to do it very comprehensively. We've all been highlighting that as well. And really, we've really focused on family. There's actually a lot of evidence that supports that the involvement of the family makes a huge difference for children's progress. We used to have an old model that was very patient-focused and not involving the family. And we've really shifted now towards having the family be really central to the progress and recovery of the patients. And we've tried to minimize hospitalization and really just use it for times where we think it's a really essential thing to be doing from a safety standpoint. Ultimately, what we're hoping for is that weight returns to normal, that the eating patterns normalize, that children, if they've lost their menses, that we have return of that, and we've avoided both short and long-term medical complications, and also just that we've been able to help the tween and the family cope with this disorder. It can be very challenging. Ultimately, the prognosis is good if it's caught early, if it's treated aggressively with specialists in the area, and in a way that involves the family in the treatment process. We have a lot of resources here at the Children's Hospital. There's an outpatient clinic where we do new patient evaluations. It's a full-day affair with individual and family assessment, adolescent medicine assessment, and nutrition assessment as well. It can be done as a one-time consultation or as a way to initiate care over time. And our intake coordinator's number is there, and then we've got a number of brochures as you leave today. We have an outpatient eating disorder clinic with adolescent medicine and nutrition follow-up, as well as child psychiatry that offers a number of treatment modalities. And the occupational therapy, it can be done through the Children's Hospital as well. We have an inpatient unit for individuals who are medically compromised to the point where they're needing to be on a medical unit, and it allows us to be treating them, but also have a number of other services available to individuals as well. Our unit is physically located at El Camino Hospital, but it's still part of the Children's Hospital. We've got our patio there and general eating areas when the children are well enough to be off their beds. We actually have a teacher even full-time that's able to be there and help the children with their studies there. And it really is a very comprehensive team that we have available to support the children, from the physician, nurse practitioner, psychology and psychiatry, practitioners, nursing staff, social worker, health educator, dietitian. We have a case manager that helps negotiate some of the insurance issues, which unfortunately can be a challenge for some families. We have recreational therapy, occupational therapy. There's some terrific art work that goes on as well. So in summary, eating disorders are present in a whole range of individuals. It's really important to get good nutrition in. You can see a lot of complications, and there's a lot of great resources out there for you to use.